irrespective of what cardiovascular disease we deal with, the ventricles rule. They influence the prognosis, they influence pathophysiology, and they cause symptoms. So one is naturally interested in the left ventricle in particular. It's been 60 years, in fact more than 60 years, when the first paper on quantitation of left ventricular volumes by angiography and derivation of ejection fraction was published. And for 60 years, for 6 decades, we are still stuck with ejection fraction. We know it's influenced by loading conditions. We know it does not manifest any abnormalities in a setting of a subtle disease. But it had withstood the test of time, and for a long time, despite many attempts, systolic time intervals, fractional shortening by M mode, mitral annular plane excursion, and different Doppler indices of myocardial performance, nothing has really come to the clinical arena. Then tissue Doppler came, the good news, and lots of papers published, and a majority of papers by probably our chairman, Dr. Samarano. The good news is that it made us think of myocardial mechanics beyond ejection fraction, strain parameters and strain rate and so forth. So it made us a little more get in deeper into the assessment of ventricular performance. But there is some bad news. It just doesn't work, okay, in spite of all these publications. Not surprising, because it's angle dependent, a big flaw, and it doesn't really track the tissue. We kind of, some of us fool ourselves it's tracking the tissue, which it doesn't. Apex is a problem, you can't see much, and other tethering and translational issues influence the data. So it's not surprising. That's where there is a potentially important role for speckle tracking. Basically, all images, ultrasound data, have black and dark images almost like our fingerprints. And you can track them. Track these things quantitatively and qualitatively. Take these 1 or 2 examples of this bright spot here, some other spots. If you follow during the course of the cardiac cycle, you can see it moves to different locations, systole and diastole, and it can be quantitatively tracked. But then, if you just do 2D tracking, if you can see the speckle in diastole, in systole you will not be able to see the same speckle because it goes out of plane. When one employs 3-dimensional tracking, all the speckles are within this pyramidal box of volume data. So even if they move, they are within the imaging plane orientation, and that's how it has a little more strength to that than conventional 2D echo, 2D speckle. Our experience is mostly based on Artida, the Toshiba system, and this transducer for 2D speckle, this one for 3D speckle. You have to collect 4 beats for a full volume acquisition. Whatever I learned about 3D speckle imaging is based on a lot of work by a variety of international fellows who have taught me a great deal working in our laboratory in Boston. And when you employ and acquire the data, you get a whole volume of data. You see a 3-dimensional image. On top of that, all the strain parameters, various parameters are displayed in many different formats. One format is this, another one is a polar display, and you get segmental data and global data as well. Now let's get into what kind of parameters can be obtained. Basically, everything revolves around displacement. Our speckle from one place move to another place. But based on that, we can derive strain, which is basically a form of deformation, strain rate, rotation, twist, twist rate, untwist, untwist rate, and torsion phenomenon. Now, let's concentrate on strain a little bit. Radial strain, strain basically means a change. Radial strain means diastole to systole, the wall thickens, And so it basically represents wall thickening. Circumferential strain, diastole to systole, this area would shorten. So it's basically circumferential shortening. Likewise, longitudinal strain is longitudinal shortening. And all of them can be displayed both as a color map and also the segmental data from different segments can be derived. And this is for radial strain, circumferential strain, and longitudinal strain. And this is what the twist data, taking the base and comparing the other regions to base. Everything rotates, but usually in the left ventricle, apex rotates in a counterclockwise rotation if you are looking from below compared to the base. So they can be quantitatively assessed from the rotation, twist, and torsional information can be derived. And you get all these numbers. First, it might be intimidating, but we have to zoom in on some important numbers. Okay, we get all these numbers. Are they really reliable? There have been a series of studies performed, both in animal models and in humans, both using 2D speckle and 3D speckle, demonstrating such information is in fact valid. Animal models, it's sonomicrometry, and in cardiac MRI, it's most of the time a tagged MRI. Let's look into some kind of whatever insights we learned and what clinical applications could be. First is the myocardial behavior. As we see, these are different segments. We can see not all of them reach the same amount of strain. It cannot. If it does, the left ventricle will not function. There is a built-in heterogeneity from base to apex. As you see, these are different strain parameters. You can see a trend coming down from base to apex. That is normal for efficient ejection into the left ventricular outflow. There is also a relation between afterload arterial elastance and circumferential strain, as you see here. Likewise, ventricular elastance, which is another parameter, a hemodynamic parameter of ventricular performance, and circumferential strain. So what we are learning is the strain parameters, while it might just represent a movement of a speckle, actually have the robust potential to provide important insights into myocardial physiology. That is all fine for research. How about clinical arena? Let's take ischemic heart disease. When you just look at these numbers, they are really confusing. Or all these beautiful curves, still, they looks nice, but it's hard to figure out what is what as a clinician. And if you give these numbers to the clinician and say, this is it, and he will throw up on you. Okay, you want to translate to a clinical scenario. Now, if you take all this data, here is one example of a radial strain. These maps show nice contraction. Yellow means good, segmental data, and the global data. Now, one of the important things to remember is we get very good information on ventricular volumes, diastolic volume and systolic volume, and ejection fraction. So the key thing, one of the things we need, we get it when you do a speckle automatically. And then regional wall motion abnormalities. Look at the color in diastole and look at the color at systole. Okay. So this is how the color changes as the strain parameters change during the course of contraction. Now, it's also easier to look at it as a map. Now we know this is good, nice weather. This is right now like Istanbul right now. And so it's easier to understand. Now, this is a nice normal contraction, all segments from anteroseptal, septal region, lateral wall, inferior wall, from base to apex, they all contract very nicely. On the other hand, let's occlude a coronary artery, or think of a patient with an LAD occlusion. And you can see all these areas in the center, basically the apex, and adjoining septal wall are abnormal. They do not show you the nice orange or yellow color. And I don't need to tell you if this is normal, this is abnormal, and this area is in the infroseptal and infraposterior wall region, easy to identify. One of the things I found over the years is trying to teach people how to, 2D echo, how to assess wall motion abnormalities. It's a challenge, really, qualitative assessment, but this makes it easy. Now, here is another same normal. Now, compare this. All the base is okay, but the apex and the anteroseptal region is abnormal, consistent with anteroapical infarction. Here is one, there are a lot of areas. This is normal, a lot of areas, here, 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 and all that. This turned out to be a patient with multivessel disease. One is even visual appraisal of a contraction abnormality. But then we can get more quantitatively, not only in understanding whether abnormality involves only the subendocardium or a transmural. Here, for example, there are two patients, one with a subendocardial fibrosis due to subendocardial MI, another one is a transmural myocardial infarction with fibrosis. Now, in this case, as you can see, subendocardial strain parameters come down, while subepicardium doesn't show much of a change. But in the setting of a transmural infarction, all of them come down. Not surprising, but now you have quantitative data. So most of the time, if you look at it, particularly longitudinal strain is sensitive, more sensitive in a subendocardial pathology. Transmural, all of them go down. And there is some suggestion that even imaging at rest, and if you derive longitudinal strain, that might predict left main or three-vessel coronary artery disease. I won't go into the great details, but this is receiver operator curves show that when you compare all this one, this particular one seems to be good. Global peak systolic strain in terms of specificity and sensitivity. Ischemic cardiomyopathy, you can see multiple areas exhibiting abnormal strain, decreased strain here, decrease here, decrease here. And so again, easier to appreciate and quantify as well. And many of these people go on to develop dyssynchrony as well with the conduction abnormalities. And you look at that, this is a chaotic set of curves. And so all the segments reaching end systole at about the same time. There's a gross dispersal. And you know very well by now that in many patients, cardiac resynchronization therapy helps and restores the synchrony to a great extent with favorable ventricular remodeling. Now, there is some indication, some measurement in diastole also might be useful, particularly looking at twist parameters. This is normal subject, and here is an abnormal subject. Someone with severe LV dysfunction also has significant diastolic abnormalities. There's a delay and diminution in many of these parameters at early diastole in particular. And there are data to indicate that it might give us some indication of the filling pressure as well. This is a filling pressure. As it goes up in the index derived from the early diastolic phenomena might indicate that whether the filling pressure is normal or abnormal. In valve disease, particularly in asymptomatic valvular disease, it has been a problem trying to decide when to operate. Or now if you take aortic stenosis, what does this slow flow, low gradient mean? And there is a lot of controversy. And some people say it's benign, some people say it's bad. My personal feeling is it's bad. But compared to a normal individual, and now there are two patients. This is a patient with normal flow and low gradient, normal EF. So that suggests this disease is probably not very severe. On the other hand, here is a low flow, low gradient, normal EF, but there is a significant abnormality in a global longitudinal strain and particularly the basal longitudinal strain. So maybe in future, some of these cases of asymptomatic individual and some of these ambiguous areas of low flow, paradoxically low flow state, what we do, we might get some meaningful information. I'm going to take the next 2 hours and go number by number. No, I'm just kidding. The bottom line is there are different groups of patients with aortic stenosis. The strain parameters might help us understand the true significance of myocardial dysfunction in some of these people. Now, another problem is this thick wall ventricle. Is it hypertrophic cardiomyopathy? Is it infiltrative disease? Or is it just a hypertensive heart disease? Here are 3 examples. This is a hypertensive heart disease without too much of a change. Here is a hypertrophic cardiomyopathy, anteroseptal area showing decreased longitudinal strain, cardiac amyloidosis, where the base is abnormal, the apex seems to be preserved. We have looked at it also, looking at twist and untwist in hypertrophic cardiomyopathy besides the strain. And you can see this is a patient, this is a control subject, and you can see the hypertrophic cardiomyopathy exhibiting increased strain here and delayed untwisting in early diastole, and that's borne out by in a systematic study as well. This is again, this is a peak twist, and this is untwist, and you can see the peak twist is increased, untwist is decreased in patients with hypertrophic cardiomyopathy. Amyloid, besides the abnormal strains, the diastolic dynamics, particularly in early diastole, might be diminished as well. So it's worth looking at in cardiac amyloidosis. Ventricular non-compaction, sometimes it's very easy to identify. Sometimes we don't know whether it's not normal myocardium with trabeculations or there is indeed a cardiomyopathy. There are a few studies, again, suggesting that if it's a true non-compaction cardiomyopathy, that area might, particularly the apex, might exhibit decreased strain. These are the trabeculations or crevices that we note. But so this needs further exploration because sometimes it is a problem. I think this disease gets overdiagnosed nowadays. In transplant patients, in the follow-up, whether they have rejection or not requires a biopsy. If one can identify rejection, even when the ejection fraction is normal, even when the wall thickness is not increased, it might be extremely helpful. These are 2 patients here, normal, transplant, normal EF, but exhibiting decreased strain. And when we looked at it systematically, about 25 transplant patients compared to controls, and many of them you can see the circumferential strain, anteroseptal longitudinal strain, and a circumferential strain in the anteroseptal area all decreased. The study continues. We'll have to find out whether it would be a good indicator of early rejection. How about the right ventricle? Right ventricular dynamics also can be studied. One just has to be careful that you acquire the data focusing on the right ventricle. This is from a study Dr. Panetta working in our laboratory did. And the normal values are somewhat equal to the left ventricle. You see this is a longitudinal strain, and you can see the peak is about -25. And there's a spectrum, of course. And it seems to be, in some of the early studies, that even in the right ventricle, the longitudinal displacement might be different and kind of may be able to help discriminate amyloid, hypertrophic cardiomyopathy, and hypertensive hypertrophy. And it might actually between a hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, if there's a regional hypertrophy and gradient, it's easy to recognize. Sometimes it's a diffuse hypertrophy and it becomes a problem. Is it infiltrative disease or hypertensive disease? And in some of the early data, Dr. Panetta looked at it, and here is the hypertrophic cardiomyopathy patients, amyloid patients. These are the mean values of global apical longitudinal displacement. You can see it is decreased in amyloid. Okay. And in patients with pulmonary hypertension, there is evidence that right ventricular strain might predict the outcome. Here is the all-cause mortality, lower the strain and higher is the mortality. And if you look at the time free from adverse cardiac events, then you can see that the lower the strain and lower is such a situation. In other words, morbidity is high. So pulmonary hypertension. And so it is feasible if we focus it on the right ventricle. And the right ventricular contraction appears to be predominantly longitudinal, and it is abnormal in a variety of disorders. So when we do overall 3D speckle tracking, it doesn't have to be only left ventricle. It could involve the right ventricle. And some early studies are focusing on atrium also, although atrial wall is a challenge. So one could conclude now that 3D speckle tracking allows you to recognize subtle abnormalities, even when the EF is normal, and of course the global dysfunction as well. Dyssynergy is easier to recognize and quantify, and maybe it could be helpful even in assessing the diastolic properties of the myocardium, and at least in some disorders, it has prognostic value. So from a kind of understanding the myocardial mechanics, we have moved on to a clinical application where not only making some early diagnosis in certain disorders and also in making decisions about surgery. And we do need more robust prognostic data to really define cutoff values where we can diagnose, prognosticate, or intervene therapeutically. And in future, besides that, online or real-time single-beat assessment and hopefully online quantitation would be extremely useful. And like many areas in medicine, it's the fusion imaging. It's not future, it's here. Dr. Zamarano will be discussing about that. So I just want to encourage you all to get involved in performing speckle tracking on a clinical basis, gain experience, go through the learning curve. Then you'll find it in a variety of conditions where we have difficulty in decision making. It could prove to be extremely valuable. Thank you for your attention.